one of the interesting questions that I get asked several times, and I actually think it's pretty interesting, is that can call light records be used as evidence? Absolutely. Anything can be used as evidence against a nurse in any type of litigation. When it comes to the board of nursing, in my experience, or any kind of regulatory body, they can subpoena whatever they want. Let me say that again. They can subpoena whatever they want. Nothing, in my experience, when I was an investigator, nothing was even allowed to be redacted. I would call and say, don't redact that. I'll decide what needs to be redacted. And that was because that was the guidance that I was given, because we needed to know what the nurse was or was not doing to protect the public. Because let me just talk about, you know, the duty of the board, the mission of the board is to protect the public. The duty of the nurse is to protect the patient. And I'll talk about my own state. 1514 says I have a duty to the patient that supersedes a hospital policy or physician order. Duty is a big loaded word. That's another thing I talk about, not only in my charting courses, my legal nursing course. Anytime I speak, duty is the big loaded word that binds us to the patient, right? Duty, breach of duty, causation, damages. Duty is what creates the relationship, and now my responsibility to that patient, that person. What is now my responsibility? That's going to depend on my level of education. My education, training, and knowledge is what dictates how I need to interact with that person. My level of education, even if I'm working as an LPN and I hold a nurse practitioner degree and I see something as and the LPN, let's just say, role, because that's how I chose to work, show up and get paid in that role. But my education, training, and knowledge is of a nurse practitioner, and I know X, Y, and Z should be happening for this patient because I have that level of education. Can I stand there and say nothing? No. Just because I show up and clock in as an LPN, that doesn't absolve me of my education, training, and knowledge, and my duty to the patient that is tied to my educational knowledge. And that's what makes it malpractice. My level of education, that negligence is different because I have a body of knowledge that now ties me to so many things. And that's going to be layered on not only from and I'm going to talk about me, my associate's degree, my bachelor's degree in science, my master's degree in science. They'll be looking at my resume. Well, what kind of type of nurse were you? Well, tell me about that. You had TNCC, you had trauma nurse court training. You worked in the ICU, you were a critical care nurse, you worked in the cath lab. All these things are just going to be layered on. So then my body and knowledge is going to have to dictate what my duty to that person was, my level of responsibility that will bind me to that person because of that, my education, training, and knowledge. I taught ACLS. I taught BLS. I just can't stand by and watch. That's not how it works for me because I am a critical care nurse who taught BLS, who taught advanced cardiac life support. So therefore, I just can't stand by and watch. That's not what my education, training, that's not how it works for me. Not how it works for any of us. So our education, training, and knowledge is what will dictate what our duty is. And the duty is the big loaded word. What a prudent nurse would or would not do in the same or similar circumstance. What a prudent doctor, physical therapist, rad tech, nursing assistant, it doesn't matter. Once you have a body of knowledge, that's what ties you to a standard of care that is upheld within healthcare and can be negligence, gross negligence, depending on your level of education and what you should or should not have known. That ties into even like boundary issues. Let's just cross over there as we, wrap this up. We got about 25 more minutes. Thank you so much for joining me. This is the annual question and answer session that I hold. If you don't know who I am, I'm Advocate Maggie. I help nurses and their legal teams when they're under investigation. I've been a nurse for 24 years in critical care. Primarily all my experience has been in a hospital setting. I've done surgery centers, freestanding emergency rooms. I've worked within a board of nursing for a short period of time. I've been a civil expert. I was a prior testifying expert, civil consultant. I don't do any testifying work in civil cases. I am an administrative assistant. I help nurses, like I said, in their legal teams. When a nurse more often than not is involved in civil litigation, but I've also helped nurses and their legal teams on the criminal side because it can affect, it will affect their board of nursing, their board of nursing, when they hold a professional license in any state. If a nurse is involved in any kind of criminal cases, charged specifically, if they're charged in any criminal cases, they will be involved with the board of nursing. There's just no way around it. I don't know that to be true. If anyone has any evidence of that, again, I'm not above learning. Please drop that in the comments, send that on over to me. In my experience, if you are charged with anything criminally, the board of nursing is going to want to know about it. Even if you're not charged, some even ask in your eligibility questions. And I helped, again, nurses and their legal teams, and we've looked specifically at the language that is being asked of the nurse, and it says, have you been arrested, versus some states say, have you been charged with anything? And each state gets to decide what they want to do. I'll talk about my own. There's no expungement in Texas. That's not how it works for a nurse. They want to know even if you've had something expunged, because their duty is to what my subscribers, the public, keep that in the front of your brain. So who do you have to protect, and who do you have to take care of? You have to make sure that you're protecting yourself, and that's layered on through many different things. Understanding your scope of practice, having a solid foundation before you start layering on any other types of possibly specialties or tasks. And so what does that mean? I talk about this, with Redonda's case. I'm doing that one. I did that one for October, November. So let's just keep on. We're doing this in November, adding on precepting, floating to other units. I'm not about that. No nurse, in my opinion, should be precepting, should not be in charge. You should not be floating to other units if you do not have more than 5 years experience. I can only think of one caveat, quite honestly. You were a medic in the military. Especially if you were deployed during any of these last wars that we deployed our active duty members, and they managed patients on a battlefield, in any of these settings. No, that's very different. Those are going to be some different caveats. If you don't bring any of that experience to the table, no, you're still learning to be a nurse. You do not have a solid foundation. And I have seen that go sideways. When you start laying on other responsibilities, let me give you some examples. Because I get asked as well. And I was asked when I was speaking at the Texas Women's University to the students. I was walking around, and one of the questions I was being asked was, do I have to precept and do I have to charge? No. Do not let any organization push you into this place. And let me just say, organizations, this is not a good move. This is not a responsible move to do this, because that nurse doesn't have enough experience. And this is where inappropriate assignments are made. There's the lack of an ability for that nurse to help another nurse to foresee things. And I'm not saying that you can foresee things, but with maturity, with level of experience, you can extrapolate things. I've been here for 24 years. I can tell you that, in my experience, that's just a fact. And why even Dr. Benner, who does stuff for, Magnet talks about the expert being 5 years, civil, or the American Association of Legal Nurse Consultants. You can't even sit for that test, that certification, unless you've been a nurse for 5 years. And please, if I misquoted that, please, again, send that on over to me, because you're not an expert. So organizations, nurses, anyone doing this, back to Redonda's case, layering on being a preceptor, floating to other units, no. Have 5 years, I speak about this, you wouldn't build a house on a foundation that wasn't solid. Why would you layer stuff on? Why would you be in charge and take on patients? And now you've been a nurse less than 5 years. That's terrifying. You can't do it. I have been a nurse in charge. The phone's ringing. I'm trying to help another nurse, and I don't take patients if I'm in charge because that's grossly irresponsible in my experience. How can I manage patients, the charge nurse, phone, assignments, bed flow, helping other nurses, and have my own patient assignment? No, that's also a disservice to that patient. No, and if something happens, I cannot say I, I, I was in charge, I was distracted, because basically what you're saying is that you knew you were gonna be distracted, and you just don't have the level of experience to do that. No, I just think that that's grossly irresponsible and sets a nurse up for failure. Let's look at Redonda. She's floating, she's precepting a nurse, and she's been a nurse for 2.5 years, and not all critical care. She worked at another facility. She had not even been an ICU nurse for a full 5 years. She was floating to other units. She was floating down to radiology, where she clearly didn't have the education, training, and knowledge, didn't know where the scanners were, because if she was floated, if she had orientation down in radiology, would have known she probably should have called the radiology nurse to let them know and let them just go ahead and manage that. It was the day after Christmas, so they may not have had a radiology nurse, but at least could have had some discussion with, maybe the interventional radiology nurse, who I believe was there during that time as well, and talked about like where the scanner is, where the equipment is, what some of the standards in that area, what she would have been expected to do, which would have meant stay with that patient when we give a IV benzodiazepine first said to the patient. But because she's been a nurse, and even in the ICU, they've not trained them for procedural sedation. Because managing a patient in an ICU, I was an ICU nurse for 15 years with a protected airway, is way different than being a procedural nurse, which I've done far longer than 15 years, because I crossed over. Very different, and the requirements for that very different. But even in her training, she's not given that either. In the unit, then she's asked to be the help all nurse. That training not sufficient enough to provide her with training in general radiology, which is a scary spot to be for any nurse. I've done general radiology, I've done interventional radiology. No, didn't know where the scanner was at, didn't know where the equipment was at, didn't know that we should be staying with the patient. Minimum should have had a pulse ox on the patient, so could have had a minimum of sat. But you see how not have being oriented in that environment was a level of disservice to everyone. So knowing your environment and not floating to environments. Another question that I get asked, do I have to have education, training, and knowledge when I float to other units? You sure do, because that's not defendable. That's absolutely not defendable. Can't say I didn't get the education, training, and knowledge. No, you didn't ask for it. I don't float to somewhere, I at least get 4 hours. And I'm most certainly not going to be a primary nurse in labor and delivery where I don't. That's cross training, have no education, training, and knowledge. Floating to another unit as an ICU nurse would be floating to step down tele. Floating to med surg would be different. I would need to be cross trained, because that workflow is very different than it is in the ICU. That may not be full 3 months. That may be just a couple of days, because that workflow is going to be very different. Minimum at least 8 hours. Where's the crash cart? How are we charting? Where's the bathroom? These types of things. Where's the Omnicell? Is my login good here? Where are the IV pumps? Where's the equipment? How do I get into that room? I need to know these types of things. So you are at minimum afforded that, and your employee file will reflect. You need to make sure that your checkbox in that area as well, where the crash cart is at. Because when you take an assignment on that unit, you are saying, I was given the education, training and knowledge. And I'm cool with giving, I'm good.